Swastika bandha. This is Anuvelita bandha. Here this Anuvelita bandha is on limbs, spiral bandage, in colles fracture, distal and radius fracture, and also in Port's fracture, bimalleolar fracture of ankle. In such conditions, we are doing spiral bandage. Here you can see the reduction method of colles fracture. In colles fracture, what we are doing is, I will explain this in detail at the concerned part regarding joints. Here just you can see the reduction method of colles fracture. In colles fracture, there is fracture at the distal end of radius within 2.5 cm from the wrist joint, with or without avulsion of ulnar styloid process, with a characteristic deformity called dinner for deformity, and the distal fragment displaces posteriorly and laterally. I will repeat. Colles fracture is fracture at the distal end of radius within 2.5 cm from the wrist joint, with or without avulsion of ulnar styloid process. In 50% cases of colles fracture, there will be ulnar styloid process fracture, which won't be united. In some conditions, in a small number of patients, there is a chance of tendinitis to this particular area after 2 to 3 years of injury. There is a chance with or without avulsion of ulnar styloid process. In 50% cases of distal radius fracture, there is a chance of ulnar styloid process fracture, and with a characteristic deformity called dinner for deformity. All of you know that dinner for deformity or silver for deformity, and the distal fragment displaces posteriorly and laterally. The displacement is posterior and lateral when compared to the anatomical position. When the hand is in anatomical position, the displacement is posteriorly and laterally. This is the displacement of radius. In clinical DAS, it is written as like this. It is the most commonest fracture. Colles fracture is the most commonest fracture. But in Athens, it is written like that. This is the fracture, most commonest fracture above the age of 40. This is the most commonest fracture above the age of 40. In colles fracture, what we are doing is traction and counter traction. Here, regarding traction, the hand should be kept in a 90-degree position. The thumb and the other 4 fingers should be in a 90-degree position, and there should be ulnar deviation. The ulnar deviation is for the correction of lateral displacement of radius. Here you can see that the thumb of the patient should be in directly forwarding towards the person who are giving traction. The thumb is in a straight line with the person who is giving traction. This is regarding ulnar deviation, and 4 other fingers should be in 90 degree to the thumb, and then traction should be given to the thumb and to the 4 fingers like this. Up to metacarpophalangeal joint, there will be bandage, so that while advising traction, it should be from distal to the metacarpophalangeal joint. Otherwise, at the time of bandage, who are giving traction, he will remove the traction so that it may cause redisplacement of the fractured fragment. So that whenever the traction begins, from the beginning itself, it should be in ulnar deviation, and separate traction should be done for thumb and other 4 fingers. Thumb and 4 fingers should be in 90-degree flexion, and the thumb should be directly forward towards the person who is giving traction. This is the basic principle regarding traction of colles fracture, and the counter traction should be given on the elbow joint like this. The counter traction should be given on the elbow joint like this. Actually, this is a particular application of marma. If we are typically giving traction over the counter traction over the cubital fossa, advise the counter traction giving person to give counter traction over the cubital fossa. Then the pain of this particular reduction maneuver will be reduced up to 50%. If we are giving counter traction over the cubital fossa, then the pain of the reduction maneuver will be reduced to 50%. So that surely make sure the counter traction should be given on the cubital fossa, and the traction should be given. The thumb should be directed forwards to the person who is giving traction, and other 4 fingers should be in 90 degree, and the person should give traction distal to the metacarpophalangeal joint. And this is the position of traction and counter traction. By giving ulnar deviation itself, the lateral deviations or the lateral displacement of the radius will be corrected. And the second correction is correction of posterior displacement or dorsal displacement of the, this is counter traction. Counter traction should be applied like this, traction should be applied like this, and then supporting the proximal fragment using the thenar eminence of one hand, using the thenar eminence of other hand, the distal fragment should be pushed downward in this particular position. It should be pushed downward. With the support of the proximal fragment is supported by the thenar eminence of one hand, and using the other hand, the dorsal displacement or posterior displacement is corrected. There is one rule: if the patient's left hand is affected, then you can use the right thenar eminence for the correction of distal fragments. If patient's right hand is affected, you can use your left hand for the correction of distal fragment. This is a basic rule, but it's of not much importance. You can forget that particular rule, but using the thenar eminence of one hand, support the proximal fragment, and using the thenar eminence of other hand, correct the distal fragment which is displaced posteriorly or dorsally. This is the reduction method of colles fracture. Here you can see we are supporting the proximal fragment with one thenar eminence, and the distal fragment is pushed downward. Likewise, it is corrected. This is the reduction method of colles fracture. First thing to be done is traction. Second is counter traction. By the traction and counter traction itself, we can feel the disembankment of fragments. Actually, this is impacted due to the fracture and displacement. We can feel the disembankment on traction and counter traction. And then on ulnar deviation itself, the lateral displacement is corrected. For the dorsal or posterior displacement, using one thenar eminence, support the proximal fragment, and then using one thenar eminence, using the other thenar eminence, correct the displacement, posterior displacement by pushing it downward. This is the reduction method of colles fracture. Colles fracture is very common. We can reduce this like this particular reduction method. And colles cast is actually the colles cast is to be done in ulnar deviation and then on palmar flexion. The colles cast should be applied on ulnar deviation and on palmar flexion. This should be applied. Here I am showing only spiral bandage. Not in this particular video, I am not showing you the cast video. And whenever there is colles fracture, I am doing a half cast bandage with one splint. One posterior half cast is applied and one splint is applied on the anterior aspect. Through the anterior aspect, we are pouring Murivanna in the initial phase. If you are not using half cast POP, then 4 splints should be applied. One splint over the posterior aspect from the metacarpophalangeal joint up to the elbow joint, and other splint is anterior from metacarpophalangeal joint to the elbow joint, and other 2 splints, one medial and one lateral, and it should be from the wrist joint to elbow joint. The lateral splint should be from wrist joint to elbow joint. If we are using a half cast, then we can avoid the posterior, medial and lateral splint and we can apply anterior splint. Half cast bandage with one splint has advantage over full cast. Why? Because if we are using this Murivanna, the stiffness to that particular joint is more reduced than complete cast bandage. So that we can provide early rehabilitation and early range of motion to that particular patient if we are using a half cast bandage with one splint. We can also use bandage with 4 splints, but the difference is that if we are giving bandage with 4 splints, rebandage is needed on every 7th day. Every 7th day, we should advise the patient to come for rebandage. If we are doing half cast bandage with one splint, first and second review should be in a gap of 7 days, and after that we can ask the patient to take 2 weeks or 3 weeks gap for rebandage. Within 4 weeks to 6 weeks, we can avoid the bandage also. The maximum period of immobilization of colles fracture is 6 weeks. In elderly people, we need more time for the callus formation, but the bandage should be removed early to maintain the rehabilitation, to preserve the range of motion, so that in elderly also there is no need of prolonged immobilization. Immobilization should be removed whenever at the absence of tenderness. The absence of tenderness is the sign to remove the bandage and start rehabilitation. Whenever there is callus formation, then there will be absence of tenderness, and in absence of tenderness, we can ask the patient to remove the bandage and then start the rehabilitation. This is regarding the management of colles fracture. Coming to this Anuvelita bandha, in Anuvelita bandha, actually we are applying a gauze initially, and then we are applying compressed cotton. Regarding compressed cotton, over the proximal area and distal area, 3 turns are needed. Over the bony points also 3 circular turns are needed. In all other area, 2 turns, only 2 turns are needed. This is regarding circular turns of compressed cotton. And then fix it with roller bandage. This is Anuvelita bandha or spiral bandage. In lower limb also, in tibia fracture, in fibula fracture, below knee cast bandage are actually spiral bandage. This is Anuvelita bandha. In this particular injury, we should apply a sling also. This is Anuvelidam Shahasu.